Good afternoon, everyone. My name is Quentin Lloyd. I'm currently one of the chief residents here in the Department of Internal Medicine. And today I have the distinct honor of introducing one of our beloved former associate program directors, Dr. Sabrina Taldone, as our first speaker today. Dr. Taldone earned her undergraduate medical school and MBA degrees from the University of Miami. Go Canes. She has also completed her residency and her chief residency in internal medicine at the University of Miami, Jackson Memorial Hospital, and then joined the faculty in 2019. She truly is a cane for life. Dr. Taldone is an associate professor here in the Department of Medicine. She's also the associate medical director for population health for internal medicine and is a devout clinical educator, serving as associate program director in the residency program here until the end of 2002, and currently a co-director in the medical school's medicine as a professions course. Most recently, she was appointed as the associate chief medical officer for ambulatory services at UHealth. Dr. Taldone holds a special place in all of our hearts here in the Department of Medicine, and is with tremendous honor to welcome her to Grand Rounds to discuss updates in general internal medicine. Dr. Taldone, everyone.
Thank you so much for that gracious introduction, Dr. Lloyd, and congratulations to you as you're rounding up your end of your chief year. Congratulations.
Thank you.
Thank you everyone for coming today. I'm excited to be sharing updates in general internal medicine with you. I love my specialty. I could fill an entire day with updates in general internal medicine, but today we'll just be focusing on some highlights. I have no disclosures. Today's learning objectives, we'll be talking about screening recommendations that are new from the CDC, and as well as a recent immunization recommendation from the ACIP. We'll touch briefly on a recent pharmacologic treatment for patients with type 2 diabetes and obesity. And lastly, discuss the trends in Medicare Advantage that I think are relevant for all specialists as well as primary care physicians. Our first case is a 40-year-old woman who comes to you. You're a general internist to establish care. She has no past medical history, no surgical history, family history as a mother with hypertension. Social history, no smoking, drinks 2 glasses of wine per week, no substance use, sexually active with husband, no children. She works as a cashier at a grocery store. The last time she saw a doctor was when she was 35 years old, but she doesn't have any copies of her previous medical records. Should the patient be screened for hepatitis B infection? Yes or no? We don't have poll everywhere today, so just want you to answer that in your head. But the answer would be yes. And this is new. So universal hepatitis B vaccine virus screening has been recommended for all adults greater than 18 years old, at least once in a lifetime. So what does this mean? It's a panel of 3 tests that should be performed. This includes the hepatitis B surface antigen, the hepatitis B surface antibody, and the hepatitis B core antibody. So all 3 of those should be done to evaluate for whether or not someone could be susceptible for hepatitis B infection. So let's take it a step further to a different patient that you see later that day. A 50-year-old male presents for a follow-up visit. This patient has a history of hyperlipidemia, no surgical history, family history as a father with coronary artery disease, no meds, no allergies. This patient is married, sexually active with his wife, no tobacco use, drinks 2 beers per week, works as an accountant. You had seen this patient before, so you had ordered screening tests for hepatitis B infection. You see that the hepatitis B surface antigen is undetectable. The hepatitis B surface antibody is non-reactive, and the hepatitis B core antibody is non-reactive. And the patient asks you, hey, doctor, at my appointment last winter, you told me that I was up to date on my vaccines, but I received a notification on my UHealth chart that I'm due for the hepatitis B vaccine, and I've never received it. So should this patient be getting the hepatitis B vaccine? Yes or no? The answer is yes. So new recommendations are not only for all infants and persons ages less than 19 to get the hepatitis B vaccine, which is an older recommendation. It's now recommended that all adults ages 19 to 59 years old receive the hepatitis B vaccine, in addition to adults greater or equal to 60 years old with factors for hepatitis B, with risk factors for hepatitis B infection. And let's just take a moment to look at some of those risk factors. The CDC and the ACIP have really tried to simplify who should be getting these vaccines to help drive the incidence down. So adults ages greater or equal to 60 years old with risk factors for hepatitis B include those with risk from sexual exposure, percutaneous or mucosal exposure to blood, and the research has shown that likely due to the opioid epidemic that we have seen an increased transmission of hepatitis B from this mode. Hepatitis C virus patients should get this vaccine, patients with chronic liver disease, HIV infection, a history of incarceration, and also international travelers. And this is just a little reminder with this map that the hepatitis B viral prevalence is greater or equal to 2 in these areas that you see in the darker colors, which are over in Asia, Africa, and parts of the Caribbean and South America. These types of travelers should definitely be getting their hepatitis B vaccine as well. Now we're going to switch away from hepatitis B at this point and talk a little bit about diabetes. So here's a patient who comes into your primary care clinic. This is a 52-year-old male coming in for a follow-up visit. Patient has obesity with a BMI of 35, type 2 diabetes with a hemoglobin A1C of 8.5%. There's no family history or surgical history that was reported. He's excited, though, that with some diet changes and exercise, he achieved a 5-pound weight loss in the past year, but this is not at the goal that he would like. Medications include metformin, 1,000 milligrams twice a day, insulin glargine, 30 units at night, and insulin lispro, 10 units before meals. So given this picture, and with the goals of improving hemoglobin A1C, minimizing the risk of hypoglycemia, and promoting weight loss, with all 3 of those goals in mind, what are the next best medications that we should be thinking about for this patient out of these options? Adding glimepiride, changing insulin glargine to insulin degludec, adding tirzepatide weekly, or adding pioglitazone. And in this case, the answer would be tirzepatide. So there was a study that was done, reported in JAMA last year, about the effect of subcutaneous tirzepatide versus placebo added to titrated insulin glargine on glycemic control in patients with type 2 diabetes. And this was highly anticipated. It's the SURPASS 5 randomized clinical trial, which I think we should take a little bit of a deeper dive into. So this is looking at tirzepatide for the treatment of type 2 diabetes. This was a phase 3 randomized controlled trial, which was conducted in 8 countries at 45 centers and in 475 adults. Inclusion criteria included adults who were with type 2 diabetes with a hemoglobin A1C between 7% and 10.5%. They were receiving insulin glargine at least 20 units per day, and they could or could not be on metformin. That was okay. Exclusion criteria, importantly, no type 1 diabetics were included in this. Any patients with pancreatitis, it was a contraindication. Diabetic retinopathy, patients with hepatitis, low creatinine clearance, these types of things were all exclusion groups. The primary outcome that this study was really looking to was to see the main change from baseline in hemoglobin A1C at week 40, comparing a 10 milligram tirzepatide dose versus a 15 milligram tirzepatide dose as compared to placebo. So let's take a look at the results, which were quite impressive. So at week 40, the mean hemoglobin A1C change from baseline in the 10 milligram tirzepatide group was minus 2.4%. And at the 15 milligram group, it was around the same at 2.34% decrease in hemoglobin A1C as compared to baseline. And in the placebo group, we do see just a minor improvement of a decrease in hemoglobin A1C of 0.86%. What was also remarkable was the body weight change from baseline per week. And we see that the mean body weight change from baseline in the 5 milligram group was around minus 5.4 kilograms at the endpoint of 40 weeks. In the 10 milligram group, it was around 7.5 kilogram loss, and 15 milligram group was around 8.8 kilogram loss. Whereas in the placebo group, as you see from the gray line up at the top, that the weight actually increased. And this would be expected, but the remarkable based on the mechanism of action of the GLP-1 receptor agonists, which bind to the specific GLP-1 receptors in the pancreatic cells to stimulate glucose-dependent insulin release, leading to slow gastric emptying, inhibiting inappropriate post-meal glucagon release, and decreasing food intake. Nevertheless, this was quite impressive. Another study that got a lot of headlines was this one that was shown in the New England Journal of Medicine last year for tirzepatide once weekly for the treatment of obesity. And this is for patients who did not have type 2 diabetes. I'm only going to touch on this superficially because one of my colleagues will be talking about obesity treatment in a few weeks, but I did want to raise everyone attention to the impact on the weight loss with this medication. As you can see, in the Tirzepatide group at 15 milligrams, a remarkable 20.9% change in body weight from baseline was achieved in this study. Recent events regarding this drug is that Eli Lilly requested an expedited FDA approval for its use to be in patients with obesity without type 2 diabetes. And currently it is being used by some as an off-label treatment for obesity without type 2 diabetes. At this point, we're going to jump into another case, but this one is going to be a little bit different. Now you're a cardiologist, you're not the primary care physician anymore. You have a 68-year-old woman who comes from the hospital discharge follow-up after an NSTEMI last week. In the hospital, she felt lightheaded and fell, fracturing her wrist. She asked you if you could refer her to an orthopedic surgeon. At the end of your visit, you try to order ambulatory referral to orthopedic surgery in the electronic medical record, which for us is UChart. And we've built this pop-up as a best practice advisory that says this is a Medicare Advantage patient. All referrals must be coming from the PCP. You can't put this in. So I thought that this might be a good time to get everyone on the same page about what is Medicare Advantage. And to everyone's curiosity, why can't the specialist place the referral? So let's take a step back first and talk about the healthcare system at large in the United States. Recent data came back. Everything is old data from 2021, but this is recently released that the national health expenditures grew 2.7% to $4.3 trillion with a T in 2021. That comes down to about $12,914 per person, and staggeringly 18.3% of our US gross domestic product. And as you can see in the chart on the right, the green line represents the health consumption expenditures as a percent of GDP. So what is the US health system spending on healthcare as compared to other countries, which are in the blue line? Often the argument is, well, we're spending more, are we getting better outcomes? And this is a very extensive area of research. I'm just showing one figure to suggest that maybe not. So using the Healthcare Quality and Access Index rating is one of the many measures that they use to compare countries to countries in their healthcare outcomes. And it shows that we are not performing better than our OECD counterparts. But this question is about Medicare. So I want to just come back to Medicare and why is Medicare expensive? So in this pie chart, you can see where the 2021 national healthcare spending was happened relative to source of funds. The biggest slices in this pie are private health insurance, Medicare, Medicaid, and out-of-pocket is close behind at 10.2%. But you see in the gray slice, Medicare was $900.8 billion in 2021 for a total of 21% of all of the spending that was in healthcare. And not in this diagram, but importantly, there is a part of Medicare called Medicare Advantage, which is growing that I think everyone should be aware about. So traditional Medicare is not the same as Medicare Advantage, even though they have the word Medicare in the name. One of the main differences is in who is paying for the benefits of this healthcare. So in traditional Medicare, the payments are coming directly from the US government, whereas in Medicare Advantage, they come indirectly from the government because the Medicare Advantage is a plan that's offered by private companies approved by Medicare. Medicare pays these companies to cover Medicare patients' benefits, and then that's paid to the providers. Medicare Advantage plans are also called Medicare Part C or MA plans. And so if you look at the Medicare Advantage enrollment by firm or affiliate, most of these beneficiaries are going to plans from either United Healthcare, which is 28% of the market, or Humana, as well as others that you see here, Blue Cross Blue Shield, CVS Health, and others. Within the last month, it's been making healthcare economic news is that half of all eligible Medicare beneficiaries are no longer in traditional Medicare. They're now more in private Medicare Advantage plans. It just crested the 50% rate. So it's got the nation paying a lot of attention to this. Importantly, we in Miami-Dade have been paying attention to this for quite some time because the Medicare Advantage penetration in Miami-Dade County is highlighted in orange here. It's actually 78%. So this is not new news for us here. The question is, how does the government incentivize the healthcare system to move from volume to value? There are many ways that public health experts try to guide the government policies towards this, but I want to go into one that is the Medicare Advantage application to our healthcare system. So in traditional Medicare, it is more geared towards volume, which is looking at how many patients did you see, how many RVUs did you generate to help decide where the funds should go. Whereas Medicare Advantage goes more towards the value side. We're looking at what were patient outcomes and how do you decrease costs, importantly, because as we looked at that pie chart and at the increasing line graph, that healthcare expenditures continue to increase in our country. This is a very simplified equation of what the heck they mean when they're talking about moving away from volume to value. So value in a large perspective is looking at quality divided by costs. So in the last several decades, there have been different iterations of how do you actually implement this at a clinic level, a hospital level, a health system level, and we can kind of look into some examples of what that looks like. But before I do, just want to talk a little bit about the math here. So if we are trying to improve value, we should be trying to improve the quality while decreasing the costs. And that's what we're going to be looking at here about how that's playing out in your day-to-day life as a specialist or a generalist. So some patient perspectives of Medicare Advantage, there are a lot of pros. It's one-stop shopping. They can buy one plan that'll cover their Medicare Part A, Part B, and Part D, which often includes the drug plan. There can be low or no monthly premiums, which is very important for people who are no longer with a steady income, especially our elderly population. They get vision, dental, and hearing usually included, and the plans are compared with one another using a star rating plan, which helps people to compare apples to apples, or at least attempt to. But there are serious cons. So there's a limited provider network. Most plans operate like an HMO, meaning patients can only go to contracted providers that are in network. Patients often need referrals from PCP to see most specialists. And this is where that example comes from with the pop-up from our case. And they usually are in annual contracts when you do have a provider. So doctors and hospitals can be in network 1 year and out of network the next year, based on what the private insurance company negotiates. Also, there are requirements for prior authorization. And also this could lead to delayed or denied access and affect patient satisfaction as well as healthcare outcomes. Some physician perspectives of Medicare Advantage. Some pros are that the payment system is a per member per month risk adjusted capitated system, meaning that you get a certain amount of payment per month that can be used to pay for services that are usually not supported financially, but now you can use it to coordinate care. This could be a patient navigator, a care coordinator, a social psychologist, things of that sort. And it also increased the emphasis on quality by paying health systems and providers higher reimbursements for higher quality. Nevertheless, there are cons. Cons include that it is risk-based. If it costs you more to take care of your patients, more than the insurance is reimbursing you for, then physicians, the providers, the health system that the physician works for could have to pay the rest of the costs. There are increased documentation requirements, which can lead to burnout, and prior authorizations are part of it. And so that's the physician and health system side. And that's a built-in mechanism to help decrease access to expensive treatments, expensive procedures, expensive specialists that may be deemed unnecessary by the healthcare company. So the take-home points on this specific area is that Medicare Advantage is value-based. It's a payment system that affects access to care, which can put limits on specialty care and medication options that aren't in network or in the formulary. There is a lot of research that is going on from a health policy aspect into this area to look at cost and quality, because unfortunately, what we've seen is that Medicare Advantage thus far has been more expensive than traditional Medicare. And the patient outcomes are not 100% clear as to whether or not this is yielding higher quality outcomes or less quality outcomes compared to traditional Medicare. Here are my references, and I'm happy to take any questions.
Dr. Taldone, thank you for that excellent presentation, those nice vignettes, which were all very informative and enlightening. Let me go to the patient that you presented with diabetes and improving diabetic control. Given his A1C and the fact that he was already on a large dose of metformin, adding another drug and keeping the metformin on board, are there any guidelines about how one handles that?
I'm glad that.
And there was a choice D that you didn't have, and that was an SGLT2 inhibitor, perhaps. Any comments on that?
Sure. So first, I'd like to address the insulin question. So in this trial, there was a protocol regarding how they could de-escalate the quantity of insulin that was required. And part of the reason for that is that we wanted to reduce the risk of having hypoglycemic episodes and also the weight gain associated with insulin. So I don't believe that step-down approach has been put in any national guidelines, but that is what they used in the study and has been shown to be a safe way to slowly decrease the amount of medication. Now, the other question you brought out about SGLT2 inhibitors, whether or not they've been seen head-to-head, I'm not 100% sure whether or not we've seen a trial with Tirzepatide looking at a head-to-head compared to the SGLT2 inhibitors and which one would be more beneficial. But for this patient in particular, obesity, the weight loss was a goal objective from this medication. And so that was one of the reasons that was more preferable to this patient in this case.
Thank you, Dr. Jones.
This is great, Sabrina. Thank you so much. I wanted to ask
Hepatology.
Yeah, I mean, I was excited for several reasons. Number one, I hope everyone realizes how high the prevalence of hepatitis B is in our community. So it's even more important for us to screen. But actually, more so for the Medicare Advantage. Actually, one of the interns, Tarisha, is working on an abstract too today about differences in access to treatment for liver cancer patients based on insurance. And I wondered if you could comment, I can tell you what we found in our data, but on rates of Medicare or managed care, Medicare or Medicaid, and how they differ based on race and ethnicity. And the other thing that I think everyone should be aware of, and maybe they are, but there are patients, for example, within our system that we care for that can't see certain specialists. So for example, a person with cirrhosis who develops HCC, I can't refer her to oncology. So you could maybe talk about carve-outs that we have and sort of what we can do as an institution.
Great. Thank you so much, Dr. Jones. And I'm happy. Thank you so much for talking about the prevalence rates. So one of the reasons the CDC made these recommendations is because the prevalence of hepatitis B nationally has been increasing. And as Dr. Jones said, we have a very high prevalence rate. So everybody should be empowered to screen for hepatitis B infection. But specific to the Medicare Advantage, so there have been studies looking at the demographics for who is enrolling in these groups. And what we are tending to find is that it is patients who have lower socioeconomic status, Hispanic patients who are Black, and for other ethnicities, we see a higher prevalence and a higher enrollment in those demographics. Something else that I think you want to get to is about denials and of using certain agents that you may want to use for patients with certain diseases. There's actually a big investigation going on through the OIG, Office of Inspector General, looking at some of these health plans because they were seeing an incomparable number of denials compared to traditional Medicare and these Medicare Advantage plans. So I was just listening to a podcast about this yesterday. They've just kind of hit the tip of the iceberg. Unfortunately, it's stuck in the courts right now because the methodology that they're using to look into some of these charts is being challenged by the insurance companies, but we're hoping within the next year to hear back from them. And then regarding carve-outs and how those things happen where you can be at one institution that maybe you want to refer to a specific specialist, but that specialist may not be covered. So within Medicare Advantage, it's through a private company. And so that has to do with the contracting that happens at the health institution level. But I would say and Dr. Colbert isn't here today, but with our institution, we have excellent contract negotiators. And so I would just invite anyone who has a particular case to either approach me and we can talk with our representatives who speak with these insurance companies when negotiating those contracts. And I'd be happy to talk with you, Dr. Jones.
In the last 2 minutes, Dr. Mark has put a question on the chat asking if you could distinguish between quality or cost differences between Medicare Advantage programs and the for-profit versus nonprofit companies like Cigna versus AvMed.
Great question, Dr. Marcus. I don't know that off the top of my my head, but I do believe that there have been some research in that area, and I'd be happy to follow up with you later. Great question.
Thank you, Dr. Taldone, for a wonderful presentation. Dr. Lloyd, please introduce our next speaker.
You got it. So next, I have the honor of introducing another one of our phenomenal physician scientists, Dr. Benjamin Diamond. Dr. Diamond currently serves as an associate professor at the Sylvester Comprehensive Cancer Center. Dr. Diamond earned his Bachelor of Science in Biochemistry at Stony Brook University in New York, his medical degree from Boston University, and subsequently went on to complete his internal medicine residency at Cornell before completing his fellowship in hematology and oncology at the world-renowned Memorial Sloan Kettering Cancer Center in New York. Under the mentorship of our very own Dr. Francesco Mora and Ola Langren in the Division of Hematology, Dr. Diamond gained research skills pertinent in the analysis of targeting sequence, whole genome sequencing, and RNA sequencing. Dr. Diamond's mission is to conduct translational research that informs clinical investigations and leads to advances in approaches to care for patients with multiple myeloma. Dr. Diamond has been able to procure several funding awards for his investigations in the use of mutational signatures to time acquisition of genomic drivers in therapy-related malignancy following primary treatment of multiple myeloma. Most notably, he has received the Conquer Cancer Foundation's Young Investigators Award, the American Cancer Society Institutional Research Grant, and even the NIH-NCI K-12 Award, which is dedicated to the use of animal residual disease models to investigate new approaches to longitudinal disease monitoring in multiple myeloma. Today, we have the pleasure of hearing Dr. Diamond discuss tracking the evolution of therapy-related myeloid neoplasm. It's with great honor I introduce Dr. Diamond, everyone.
Thank you, Quinn, for that really kind introduction. I'm very happy today to be discussing some of the research we're working on over in the Myeloma Institute. And actually, this is it's a nice thing because I started talking about this with you guys maybe about 18 months or so ago. And I now have some updates for you since we've gotten here. We've published a nice piece of work in Blood, and we'll be talking about that. So I do like that there'll be some continuity in some of the work that we're talking about. So for starters, here are my disclosures and the outline of today. So we are going to be delving deep into some science.
We don't see your slides, Ben.
Oh, I'm so sorry. 1 second. Don't know how that happened. How about now?
We're good.
Okay, great. Must have lost him. So we're going to be delving deep into some science. And for that reason, before we can even talk about the recent publication, which is chemotherapy signatures in therapy-related myeloneoplasm, we do have to cover just a little bit of background so that we can all be on the same page here. And so our work is primarily on mutational signatures over in the Myeloma Institute, specifically in the genomic laboratory. And so the basic idea is that I think all of us are familiar with human cells developing mutations over the lifespan of the cell. This is basically the hallmark of cancer. As people age, cells divide, and with each cell division, new mutations are accumulated until eventually, and unfortunately, a cell with enough driver mutations can clonally expand and become a tumor. Now, the idea, though, is that each of these mutations that are being accrued over time are due to different processes, and different processes might be active at different time points. So, for example, there are mutational processes that happen constantly throughout life. There are some that are activated only for a brief instant. There are mutations that are basically accrued in small time periods. There could be exogenous mutational processes, such as the exposure to chemotherapy or the exposure to ultraviolet light, for example. And all of these things together contribute to the total tumor mutational burden. And so it would be really nice if at the end of the day, when we perform our whole genome sequencing and we look at all of the mutations in the tumor at a single point in time, if we could go back and figure out which mutation was due to which process, so we could really understand tumor evolution. So it turns out we really can do this. And so what we're looking up in the top left over here in this bar plot is a depiction of all of the mutations contributing to the tumor mutational burden of a single tumor. And what we can do to understand which processes are contributing is to subdivide each mutation into a different class, right? So there are 6 subclasses, as you see on the top, C to G. There's actually a typo there, but there are 6 different subclasses, and each of those mutational subclasses can occur within a specific trinucleotide context. So for example, a C to G could occur in the context of a 5'A and a 3'T, and vice versa, until there are basically 96 possible combinations. And through some mathematical modeling, we can extract which signatures are contributing to the sum total tumor mutational burden. And at the end of the day, each of these signatures is visible within the tumor mutational burden. A similar analogy can be basically sheet music. So every single instrument is producing a different melody, different notes, but at the end of the day, they all contribute to a score. And so in that score, although it is one total song, you can still pick out each of the individual instruments basically as you hear them. And the same is true of these mutational signatures. So these are the 4 mutational signatures we're going to be talking the most about in this talk. So the first is SBS5, and I mentioned earlier that there are mutational processes that occur at a constant rate over time, and this is one of them. Basically, we think this is due to an endogenous deaminase, and so as cells divide over time, almost constantly, like clockwork, these cells are going to acquire mutations within these specific patterns. Now, conversely, though, SBS 31 and 35 can be linked to the exposure to platinum chemotherapy. So chemotherapy can be mutagenic, platinum especially so, and this is what it looks like when cells are exposed to platinum. And the last is SBS MM1, which is a mutational signature that's been discovered by our group. It's actually associated with the exposure to melphalan chemotherapy, which is quite common in lymphoid neoplasms and especially in multiple myeloma. So now how do we use these signatures to actually characterize tumor evolution? How do we leverage them? I first start talking about the clock-like signatures, so SBS5, as we just discussed. There was a really big study done by the PCOG consortium, published in Nature, that basically showed that SBS5, or this clock-like mutational process, can be accumulated, as we said, at a constant rate over time per patient, per tumor. So every patient will have a unique rate, but that rate is constant over time. And so we can really leverage that to understand when certain events occur within tumor evolution. One of the ways we've used this, for example, is by timing basically large chromosomal gains. And so the basic concept is this: you have 2 chromosomes or 2 alleles, you've got a mutant on one of them, and if that chromosome is duplicated during oncogenesis, then also the mutations that are on that chromosome are likewise going to be duplicated. Now, if you imagine an entire suite of clock-like mutations that have been accumulated over the lifetime of the organism, those mutations are likewise going to be duplicated. And so what we can actually do then is, looking in the context of these gains, we can compare the number of duplicated mutations to the non-duplicated mutations to actually come up with a time, an absolute time at which this large chromosomal gain was accumulated within a patient's life. And so luckily for us in multiple myeloma, tumor initiation is characterized by these large chromosomal gains. And so in a study that we did previously looking at multiple myeloma tumors that had been initiated by these large chromosomal gains, we actually said something very, very interesting. And that is that these large chromosomal gains, these initiating events, are happening to patients in their 20s and 30s. And the latency is on the order of 50 years for the patient's primary tumor to be diagnosed, which means that the tumors are actually initiating very, very early in life and take years upon years to come to clinical significance. Well, that's one of the ways we can use these clock-like signatures. Now, when we shift gears to start talking about some of the other mutational signatures, like chemotherapy-induced signatures, these are a little bit more idiosyncratic, and they have different uses. So where the clock-like signatures can be accumulated over time at a constant rate, the chemo-induced mutations are going to happen at a single defined time point. And we actually have great annotation for that just by looking at the medical chart. We know exactly what time point these mutations were accumulated because we know when the chemo was administered. And so with that in mind, we have to understand the concept of single cell expansion. So if you have a tumor, each of those cells that are constituting the tumor are all going to be exposed to chemotherapy. And although they're all going to accumulate mutations in a specific pattern, in that SBS 31 or that 35 pattern, the actual catalog of mutations, the unique mutations that each cell is going to accumulate, are going to be unique. And so when we actually do whole genome sequencing on the tumor itself, The only possible way for us to measure the chemotherapy-induced mutational signatures is to have one single cell that had a catalog of chemo-induced mutations expand to clonal dominance. And only in that way are we going to be able to see mutations at a variant allele fraction that is high enough, basically mutations that are clonal, that we're able to measure these chemotherapy-induced signatures. On the other hand, if you give a tumor platinum or melphalan and there's basically no response, all those cells are still going to accrue those mutations. But when you whole genome sequence them, all the DNA molecules are jumbled together, and all of those mutations are going to be subclonar. We're never going to be able to measure that at the scale of whole genome sequencing, and we won't be able to measure those mutational signatures. And so with that in mind, we had performed this study, a pretty cool autopsy study back at Sloan Kettering, where we had 4 patients with multiple myeloma who unfortunately succumbed to their disease. And we performed whole genome sequencing of different biopsied sites across their bodies to try to understand how those metastatic sites basically had been seeded, where they came from, was their initiating cell, how do we really time those metastatic events. And you see below, there's the therapy history for each of these patients, with the arrows basically denoting the mutagenic chemotherapy exposures over the lifetime of the patient. I pull out just one of those phylogenies just for the sake of time. So on the left here, what we're looking at is the tumor phylogeny for one of these cases. And this is a patient that actually got melphalan twice, as you see in the red arrows, and in the green arrows, platinum twice. And so by looking at each of these branches, what you can see is the tumor mutational burden in the trunk that is shared by every single one of those biopsied sites. You have sites in the calf, the lung, the gallbladder, et cetera. Those mutations in the trunk are shared clonally across all of those sites. And so when we run our mutational signature analysis across those mutations, we do see that SBS-MM1, the melphalan-related mutational signature, is present in the trunk. And the only way to explain this is that because those mutations are shared across all of these different extant sites, basically one single cell that survived the exposure to melphalan multiplied and spread and seeded the entire body at relapse. Okay, so there was one surviving cell, seeded the whole body. And then you see that there are unique melphalan mutations in each of those subsites that shows that during that second exposure, those cells did not have a deep enough response in order to have basically a unified clonal mutational signature. They each have their own unique melphalan-induced mutations. And so what's kind of nice is that we can then pair this to imaging and actually see that the timeline sort of matches. And so we can basically pin down where that single cell was to a site within either of the right pleura or the right chest wall that likely seeded the rest of the body after the exposure to melphalan. So that's one of the things that we can do. Now we want to look at how we might be able to time these events in therapy-related myeloid neoplasms, which are a big problem in multiple myeloma. This is the paper that we just published in January with a lot of help from members of this institution and others. And so a little bit of background here. So one of the primary treatments in multiple myeloma, almost all fit patients are exposed to this, is a treatment of high-dose melphalan, which is a chemotherapy, and then autologous stem cell transplantation. The basic idea is that this is a consolidative approach to treat patients with multiple myeloma, but unfortunately, it's associated with a very high rate of developing a therapy-related myeloid neoplasm as a secondary tumor following the exposure. We saw in a recent trial looking at VRD and transplant versus VRD that only the patients in the transplant arm were developing this complication. We also know that pre-existing clonal hematopoiesis is a risk factor for this. And the idea is basically that these pre-leukemic cells that are present in many, many people are basically precancerous lesions. They are clonal outgrowths of cells with leukemic driver mutations. The assumption is that they are exposed to chemotherapy, and in some way that chemotherapy exposure is triggering them to expand later in life into a therapy-related leukemia. And we do see that obviously these therapy-related leukemias are quite dismal in prognosis, and the incidence is predicted to rise over time, mostly because the overall survival for patients with multiple myeloma is getting very long, fortunately. So patients are unfortunately suffering the consequences of some of the therapies that they received in early lines. So we wondered whether we could use the chemotherapy signatures to understand how that CH might be evolving into therapy-related myeloneoplasms. So we performed a whole genome sequencing study of 40 TMNs from 39 patients. We also looked at some de novo AMLs, and then we also looked at pre-chemotherapy samples using targeted sequencing to see if we could detect pre-existent clonal hematopoiesis. And here in some of the charts, you see the overview of which patients received which therapies, where the primary tumors came from. And you see that basically half of the cohort were patients with multiple myeloma, and the others were patients with solid tumors exposed to other agents. And many of these patients received tons of therapy. So the first thing that we noticed was looking at the TMN, specifically looking at their mutational burdens. It was the patients that had been previously exposed to melphalan and platinum that had the highest tumor mutational burdens, here measured in SBS, which are single base substitutions. So just looking at those simple mutations. So they're much higher in the melphalan and platinum exposed cases. So the next thing that we wanted to do was to look at each individual tumor and to tell whether those chemotherapy-induced mutations were present there. And so to orient you here, every single column here represents one patient. They're separated by tumor histology. So we have some de novo AMLs, we have some relapsed de novo AMLs, and we have our TMNs. And the assumption was going to be that given the long period of time that it requires to receive chemotherapy, have a few years and then develop a TMN, the assumption was going to be that every patient that was exposed to chemotherapy was going to have a chemotherapy-related mutational signature within their TMN. And so we do see that that was the case, absolutely, for platinum. Every single patient that received platinum earlier in life, we were able to measure a platinum-associated mutational signature within the tumor. But for the patients that received melphalan, only about a third were displaying the melphalan signature, right? So this was something that we really were not expecting. We're really trying to figure out why, where this highly penetrant mutagenic agent wasn't inducing mutagenesis within these TMNs. And so we came up with the idea that it's actually the procedure itself that's allowing these cells to escape the exposure outright. So within an autologous stem cell transplantation, what ends up happening is that because the treatment is so toxic, it's so myeloablative, what you need to do is collect a patient's stem cells prior to the treatment, freeze them, put them in a bag, and use them as a rescue device, right? So you're giving that patient melphalan, it wipes the entire bone marrow clean, normal cells, myeloma cells, you name it, and then you have to rescue that patient by performing that transplant. And so if the leukemic stem cells, basically, if that CH is present within the apheresis product, they can be reinfused back into the patient, and it basically escapes the melphalan exposure outright. So we wanted to test if this was true. And we performed, as we spoke about earlier, that targeted sequencing study of the pre-chemotherapy samples. And here you can see that clonal hematopoiesis is present in each of the samples that we tested. And moreover, that clonal hematopoiesis is also present in some of the apheresis samples that we tested. Those are annotated by that little stem cell bag there, really showing that these CH mutations can indeed be reinfused back into the patient. And importantly, I should mention that all of these mutations are the mutations that became clonal within the TMN itself, right? So we know that these are the pre-existent CH, they are exposed, they evolve, and they can either be exposed or they can escape the exposure within the apheresis product itself. So we next wanted to look at the difference, right? So all of those melphalan exposed cases, we're wondering, okay, so some of these have chemotherapy mutations, they have a higher tumor mutational burden, and the ones that don't have those chemotherapy-induced mutations seem to be simpler, they have less mutations. So we wanted to look at the other aspects of the genome to really understand the other differences that we're seeing between those two groups, the chemo-mutated and the chemo-non-mutated groups. And so what we see by looking at the copy number events is that the TMN that have chemotherapy signatures that are hypermutated do indeed have very complex genomes with multiple aneuploidies, deletions, gains, you name it. And the TMN that are not chemotherapy mutated actually look pretty similar to the de novo AMLs, suggesting that there are two distinct mechanisms of tumor evolution. We next compare the structural variants across all of these samples, and we see basically that this corroborates what we're seeing with the copy number events. And a lot of these complex structural variants, which I'll talk about in a couple seconds, including chromothripsis and chromoplexy, are present really only within the TMN with chemotherapy signatures. Now, onto the chemotherapy signatures themselves and the chromothripsis. So chromothripsis is basically a shattering of the genome with a haphazard repair, insofar as that all of that basically within one catastrophic mitosis, multiple driver mutations and copy number variations can be acquired all in one. And what we're seeing is that basically this is highly enriched in the patients within the chemotherapy mutational signatures. And then looking at just those patients that had the melphalan-induced mutational signature, every single one of them had a TP53 aberration. Compared to those 10 cases without the melphalan signature, only 2 TP53 aberrations there. It's really suggesting that the type of clonal hematopoiesis governs which kind of expansion you're going to have. And so we refine our model just a little bit here, in that with a wild type TP53 clonal hematopoiesis, myeloablative melphalan is doing exactly what we intended it to do, and it wipes everything out. So it kills it. And the only way for these TP53 wild type CH to expand is for them to be pheresed off and to be reinfused into the patient to expand to TMN, likely in an immunosuppressed environment. Then for the TP53 mutant CH, here, these cells are pretty nasty, and they can actually survive the exposure to the myeloablative melphalan, and it takes TP53 aberration in order to be able to survive the immense genomic damage that melphalan is causing. And here we see the complex genomes that are being caused there. Alternatively, they can be reinfused, but we saw that basically in order to have the melphalan-induced mutational signature, you had to have a TP53 mutation to start. I mentioned before the chromothripsis. I wanted to show you more in depth to highlight some collaboration that we're working on here. So basically, among all of the chromothriptic events, we noticed that there was basically a novel driver that was only present in the chemo-mutated TMN. What you're looking at here are mutagraphs that display chromosome 19 in its entirety for 5 different cases. And in each of these cases, the black horizontal line that is fragmented is the total copy number. And what you can see is that at the focus of SMARCA4, which is a driver gene in some other cancers, we do see that there is hyperamplification across 5 cases of chemotherapy mutated TMN. We wanted to really test whether this was a true novel driver. This is highly unusual, I would add. And we had we did a collaboration with the Taylor lab, where Taylor and his colleagues transfected SMARCA4 into leukemic stem cells in a cytokine independence assay, and demonstrated that indeed these cells with constitutively active SMARCA4 were able to grow as compared to vector in the absence of stimulation. And then finally, I will talk about using these large chromosomal gains in TMN as a chemotherapy barcoding technique that is applicable to many different malignancies. And so we can use it basically that the applications are pretty exciting for us. We talked earlier about the concept of duplicating duplicating mutations across chromosomal gains. And so here the concept is the same. If a chemotherapy-induced mutation is acquired prior to a chromosomal gain, that mutation is going to be duplicated across the gain. And conversely, if the gain has already occurred, then each chromosome is going to have a unique set of chemotherapy-induced mutations. I show you one example here of a copy-neutral loss of heterozygosity, where there was previously a deletion on chromosome 5 and chromosome 7, and then a duplication of the remaining allele. And pulling out below the plot of all of the mutations that are present within these segments, you see that the majority of them are duplicated. They have a cancer cell fraction of 100. And looking at the molecular time plot on the right, that's basically congruent with the idea that these events, these LOH events, must have occurred very, very late in tumor evolution, where 1 is the time of tumor sampling. Basically, what we see is because all of these mutations are duplicated, all of the mutations that had been accumulated prior must have also been present at the time, right? And so they're duplicated very, very late. Looking at a mutational signature analysis across these duplicated mutations, we do see indeed that the melphalan signature is there. And this confirms, for the most part, that melphalan was given, and then the duplication occurred following, very, very late in tumor evolution. Now, to demonstrate this, we basically did this across all of the eligible tumor types that had a gain that was big enough for us to measure. And we basically see that in every single TMN that we looked at, the large chromosomal gains were accumulated following the chemotherapy exposure. And to make sure we weren't crazy here, we looked at some multiple myeloma cases, just 2 of them, where multiple myeloma was actually the second cancer. And they had previously had a primary solid tumor exposed to platinum chemotherapy and developed later a secondary multiple myeloma. So here are the two multiple myeloma cases in the context of basically unexposed chemotherapy, newly diagnosed multiple myelomas. And we see that the rate of their SBS5 accumulation is very similar. So they're basically indistinguishable. And using our molecular time approaches, we do see that the large chromosomal gains that these tumors did have happened pretty early in life, as I mentioned before, right? Back in their 20s and 30s. And then the gray dot there is the diagnosis of their technically their primary tumor, which was a colon cancer and an ovarian cancer. They're exposed to chemotherapy at that time, and only later did they develop their TMN. So when we reconstruct the tumor evolution, we basically see that in multiple myeloma, at least, the initiating events are, as we spoke about before, they are early events, and only later is chemotherapy being administered and probably not having much of an effect on tumor evolution at all. This is completely the opposite in the TMNs. And what we see here is that by combining our targeted sequencing and the chemotherapy barcoding, we see that basically in every case of TMN, there is pre-existing clonal hematopoiesis, right? This is known. We know that these CH mutations are a risk for developing the TMN, and so it makes sense that they should be there beforehand. But then it is only the exposure to the chemotherapy that sets things off. And we actually see that all of the complex events that we're measuring, the chromothripsis, the large gains, the whole genome duplication, all of these things are happening after the exposure to chemotherapy and may indeed be being caused by the chemotherapy itself. So overall, we see that all of these complex events appear to be acquired following chemotherapy exposure, that the therapy signatures allow us to time the acquisition of the events in relation to the exposure, that we can use this same technology and the same technique to understand the drivers of resistance across tumor histologies, and that there are two main routes to TMN development. There are the cases that are hypermutated, that acquire complex drivers following chemotherapy administration, and there are cases that do not survive the exposure to chemotherapy and may only survive via the apheresis and a transplant, and then further be selected in an immunosuppressed environment, basically as a result of chemotherapy. Oh, sorry. I missed my thank you slide. Here we go. and with that, I would like to thank you all for your attention. I know we got pretty deep in the weeds. I hope that some of this was relevant to you, and you can see some of the work that we're working on all together at the Myeloma Genomics Lab, led over by Francesco Mora and Ola Langren. Thanks so much for your attention.
Thank you, Dr. Diamond, for that very interesting presentation. Maybe I can begin by asking you a question. In terms of our understanding of the timing that we give a chemotherapeutic agent, let's take in this case melphalan, and the timing that it takes to develop these deleterious mutations or mutational aberrations that end up resulting in another cancer, another problem. Have we learned anything about how long we need to give chemotherapy for, where you get the anti-tumor effect, but you don't induce the mutational problems?
It's a really tough question. I think, based on the work that we're doing, basically the chemotherapy, we're using it more as a barcode to try and understand how tumors evolve. I'm not so sure we can say, basically, based on these barcodes, the length of time it's required. I can tell you, though, that any small amount of these agents is enough to cause the mutations, right? So no matter how little we give, we are still inducing mutations. I don't know the specific threshold, though, at which enough mutations are going to be accumulated that we develop some of these complications.
It would seem to me that you'd be able, cells divide relatively quickly. I mean, you should be able to pick up when the minute this mutation occurs, that's when the risk-benefit ratio of the chemotherapeutic agent may be a problem for you. But ultimately, I guess that's just one of the many things that you can be looking at here. Thank you. Dr. Zawid, you had your hand up. You have a question? Maybe not. Okay, any other questions? If not, I'd like to thank both our speakers today for really excellent grand rounds, and I look forward to seeing you all next week after the Memorial Day weekend. Thanks very much. Please don't forget to look at the chat in order to link to the CME and the MOC credits for these lectures today. Thank you again, Dr. Diamond and Dr. Taldone. Have a nice day.
Thank you.